We're going to talk and kick our afternoon off with antibiotics. And I entitled this section, You Just Have to Know This Stuff, because you just have to know it. And I used to not teach this as part of the course. I didn't. And then people struggled so much with antibiotics, I included it. And one time when I didn't include antibiotics, there was an uproar from people. And they're like, Amelie, we need those antibiotics. So listen, you aren't the only one who struggles with antibiotics. Your colleagues in practice do as well. So here's my goal. I want to give you in about 43 minutes time what you need to know to be a savvy prescriber. All right, so here goes. We're going to talk about antibiotics, and I am convinced that I can teach you to be a savvy prescriber if you master two concepts. And really, though, both are very, very easy. The first thing you have to be able to do is know the difference between gram-positives and gram-negatives. Very easy. The second thing you need to be able to do is know why the beta-lactam ring is so darn important for you. Because if you're going to sign your name on a prescription, you got to know about the beta-lactam ring. So we'll talk about that. And those two concepts really are pretty easy to master. Once you get them mastered, then we're going to go right into why we use what antibiotic for what infection. And I think it'll come together. All right? So let's get going. Excuse me. So let's talk about gram-positives and gram-negatives. You know, in humankind, we have males and females. In the bacterial world, we have gram-positives and gram-negatives. And just as it is with humans and patients, you got to know, is this patient a male or a female? You got to know, have a really good idea, whether the bug making your patient sick is gram-positive or gram-negative. And you got to know which is which. So it's really very, very easy to learn which bugs are gram-positive and which ones are gram-negative if you'll simply remember this. Just remember that there are 3 gram-positive bugs of clinical significance for all of us in primary care. Here they are. Ready? Staph, strep, and enterococcus. Staph, strep, and enterococcus, and there's one more you'll see. C. diff. All right? So listen to the names of the 3 gram-positive bugs again. Staph, strep, and enterococcus. And oh yeah, C. diff. If the first name of the bug is not staph, strep, enterococcus, or C. diff, it's going to be gram-negative. Like, how easy is that? Now you know every bug on the map. You know every single one of them. Well, with that said, you got to know about staph, strep, and enterococcus. So let's talk about staph first. Staph, obviously, is short for Staphylococcus. And probably the first staph organism that you learned about was Staph aureus. And so Staph aureus is really a smart little bug because it's learned how to become resistant. So we have this organism called methicillin-resistant Staph aureus. What's another name for it? MRSA, exactly. So it's learned how to be really highly resistant. The run-of-the-mill Staph aureus that you know, it's probably on your skin right now, probably on mine, is methicillin-sensitive Staph aureus. So when you think of staph, I want you to think of it mostly as a skin bug because staph is on your skin. And that's what I want you to think. Staph saprophyticus is a staph organism, and it's unusual. It's unusual because it's in the urinary tract and in the vagina, especially in women who have multiple sexual partners. All right? So it's just unusual in that there's a gram-positive bug below the belt. All right? And it's called Staph saprophyticus. And then finally, there's another staph organism on your skin. It's called Staph epi. But generally, if you will just think staph, it's a skin bug, you'll be in a good place. Does everybody have it? All right. The second of the gram-positive bugs is strep. You just call it strep. Its like real name is Streptococcus. It's like when somebody's name is Elizabeth and you call them Liz. Well, we say strep, but the real name is streptococcus, all right? So what do you need to know about strep? I'm pretty sure that every one of us in this room has had strep throat. The organism that caused strep throat in you was Strep pyogenes, specifically Group A, beta hemolytic strep. All right, Group A and beta hemolytic are just two characteristics of strep. But Strep pyogenes is an important bug. We'll talk about it tomorrow when we talk about ENT. This morning, when we looked at pneumonia, and we looked at comorbidities, and we used that to determine what antibiotic we chose for a patient, what we were really doing with comorbidities was looking at patients who probably have strep pneumo, Streptococcus pneumoniae, because strep pneumo is a bad little bug. It's a very bad little bug in that it's associated with the highest rate of mortality in outpatients who have pneumonia. Strep pneumonia is not a good one to get. And that's why when a patient came in with that, we tossed out our best antibiotic, like a respiratory quinolone. Dentists, when they give antibiotics for a tooth abscess, are also treating a strep organism. The name of that organism is Strep viridans. And I don't know if anybody's clued you in or not yet, but you are never going to believe how many patients come into primary care with a dental complaint. In fact, usually they're in a whole lot of pain, and honestly, there are only three things you can do for them. You can give them an antibiotic to treat Strep viridans. You can give them something for pain. And the third thing is you can get them to a dentist, and not necessarily in that order, right? So you got to try to get them in to see somebody, but you'll see your share of dental problems. I had no idea people were coming in with so many dental problems. And then finally, how many people in here take care of pregnant women? If you take care of pregnant women, you work labor and delivery, you're on the lookout for strep also. The name of that organism is Group B strep, right? Strep A galactiae. That's a normal inhabitant of the female vagina. Like if you have a vagina, you probably had some of that in there right now. And I'll be really worried if you're pregnant, because if a baby comes through that canal that's infected with Strep A galactiae, that is going to be one sick little baby. Consequently, the point you should take away right now is that strep in any of those forms is a bad little bug. All right, it's a bad actor. So staph, strep, and the third of the gram-positive organisms is Enterococcus. If you don't know anything about Enterococcus, just know it's a urinary tract pathogen. It's a urinary tract pathogen. Just so you'll know, the E of E. coli is not Enterococcus. The E of E. coli is what? Escherichia. You know, Escherichia coli, that's that bug's name. And I was thinking, if my first name was Escherichia, I'd want them to call me E also, you know, E. So, E. coli. So, give me the 3 gram-positive bugs again. Staph, strep, and Enterococcus. And sometimes C. diff. There you go. So, what about C. diff? You're going to see that one in primary care, not every week, a couple of times a month probably. And, you know, people come in with it, and I'm going to show you how to get rid of the organism, not the patient, in a little bit. These are some other examples of gram-positive bugs, but you know, as you look at them, you realize that in clinical practice, you're not going to be seeing people who come in with diphtheria. They're not coming in with botulism, tetanus, or anthrax. All of those are gram-positive pathogens. If you will just remember staph, strep, Enterococcus, and C. diff, you got it. All right? And everybody right now has it, so I'm moving on to the next point. The second point that you have to master to be a savvy prescriber of antibiotics is why the beta-lactam ring is so darn important. And you might be sitting there having this thought, Amelie, I don't even know what a beta-lactam is. I think I might have heard about that from pharmacology, but I really don't remember. Well, let me remind you about why it's so darn important. And I'm going to make you a chemist in about 16 seconds. All right? Look at how easy chemistry is. This is the chemical structure of penicillin. Every penicillin on the planet looks just like this. Its chemical structure includes this pink pentagon and this blue box. The blue box is the beta-lactam ring. Every penicillin on the planet chemically looks just like that. Every cephalosporin on the planet is made up of an orange hexagon and a blue box. The blue box is the beta-lactam ring. So when somebody says, what's a beta-lactam antibiotic? It's any penicillin or any cephalosporin. Now, why do you even need to know about the beta-lactam ring, that blue box? Well, if you're ever going to sign your name on a prescription for a cephalosporin or penicillin, you got to know about the blue box. And the first reason you must know about the blue box is because of allergic reactions. So listen, you're going to be in your exam room, and you're going to want to give a patient a penicillin or a cephalosporin, and the patient is going to look at you and say, I'm allergic to penicillin. The real question is, can you give that patient a cephalosporin? And the answer is, it depends. And let me show you what it depends on. If you're penicillin allergic, you are either allergic to the pink pentagon or you're allergic to the blue box, but you're not allergic to both. Listen to it again. If you're pen allergic, you're either allergic to the pink pentagon or you're allergic to the blue box, but you're not allergic to both. So, newly ordained chemists, if you're pen allergic and you're allergic to the pink pentagon, can you safely take a cephalosporin? Yes, because there's no pink pentagon in the cephalosporin molecule. Newly ordained chemists, if you're pen allergic and you're allergic to the blue box of penicillin, can you safely take a cephalosporin? No, you're going to be allergic to that one too. Well, it would be really nice if when people came in and said, I'm pen allergic, they would say, it's the pink pentagon, I can take the cephalosporins. But they don't tell you that. So how are you going to behave? Well, you're going to consider this, and then you're going to follow some rules. Let me show you what you're going to consider. The first thing you consider is that when people are allergic to penicillin, they're almost always allergic to the pink pentagon. In fact, numerically, here are the numbers. 90 to 98% of penicillin allergic people are allergic to the pink pentagon. So you know what that means? 90 to 98% of penicillin allergic people can safely take a cephalosporin. The odds are in your favor, even if you know nothing else. But that's taking a chance with a patient, and we're never going to take a chance with a patient. It's not very common for people who are pen allergic to have an allergy to the blue box. But as you told me, if they're allergic to the blue box, they're going to be allergic to the penicillins too. It just turns out not many people are blue box allergic. So how are you going to behave? They're not going to tell you when they come in whether it's the pink pentagon or the blue box. So here's how you're going to behave. You're going to follow what I call the 3 rules. And today they're Amelie's rules, but they're your rules, because they're the rules of any safe prescriber. Here's rule number 1, you already know it. We never give a cephalosporin to a patient whose reaction to penicillin was anaphylaxis. Never, not ever, you're never going to do it. Because suppose that pen allergic patient is blue box allergic, and you give them a cephalosporin, they're going to have anaphylaxis with that one too. And you know, you are doggone lucky if you survive 1 episode of anaphylaxis. The chance of having 2 episodes and surviving both of them, if you do, as I tell people, you ought to take your money and go to Vegas. You should. You're lucky. You're just that lucky. So rule number 1, you know, we never give a cephalosporin to a patient if the reaction to penicillin was anaphylaxis. Rule number 2, I think you know, we don't give a cephalosporin if the reaction to penicillin was hives. And here's why. When you see hives in a patient, regardless of what it's from, anytime you see hives, it always means a real allergic reaction. You know what a real allergic reaction means? It's IgE mediated, immunoglobulin E. What does that mean? It means that there's a war going on inside of you. And clinically, you should know this. Anytime a patient has an allergic reaction that's IgE mediated, listen to it. It escalates over time with repeated exposure. It escalates over time with repeated exposure. That's what an IgE mediated reaction does. So it might be hives when I gave you penicillin, but if I give you a cephalosporin and you're allergic to the blue box, it might go from hives to what? Anaphylaxis. So the rule is, if it's hives, no cephalosporins for those patients. Now, the rule you're going to use most often is rule number 3. Rule number 3 says we want you to give a cephalosporin if the reaction to penicillin was a morbilliform rash. What in the world is a morbilliform rash? A morbilliform rash means it's not IgE mediated. It means it's not IgE mediated, and it doesn't worsen with repeated exposure. So let me show you something. When you look at a morbilliform rash, I want you to look clinically for the differences between hives and a morbilliform rash, because people don't come in and say, "Oh, Dr. Amelie, it was the morbilliform rash." What do they say? "I had a rash." And they shouldn't be able to tell you. But when you ask them this clinical question, the clinical question you ask somebody who says, "Oh, I had this rash with penicillin," you always ask them, "Did the rash itch?" That's what you ask them. Because hives, look at this. This is hives. It's raised, it's red, and it is highly pruritic. So it itches like crazy. Nobody has asymptomatic hives. But with a morbilliform rash, if you ask this patient, does it itch? They say, "Well, yeah, it itches a little. When I got out of the shower this morning, it itched." That's not hives. People who have hives are miserable. They feel like they want to jump out of their skin because they itch so bad. Remember, there's a war going on inside with their immune system. So it's IgE mediated. A morbilliform rash, that's not the case. It's an allergic reaction, but it's a type 4 reaction, and it doesn't escalate over time. All right? So big difference. The clinical question you ask them is what question? Does it itch? Exactly.